All right, welcome everybody to the Go Wellness Collaborative. This is your host today, Kate Archibald, and I am joined by two healthcare badasses. I got Dan Kellums from Denver, Colorado area, functional medicine provider, doctor of Oriental medicine, and along with Dan is we got Dr. Jeremy Stitch. And just a phenomenal functional medicine doctor, has an array of knowledge in functional medicine, health. He's worked in all sorts of different areas in the healthcare world, and so I'm really excited to dive into some cool stuff.
Well, let's start with the thing that probably annoys both of us the most, which is when people come and they give us the list and they're like, this is what I take. I take it every day and I'm religious about it. I'm like, okay, how's that working for you?
Yeah.
And there's some good science behind why you have to cycle anything that you're using, whether it be peptides or supplements, to avoid this idea of tolerance. So, why does it matter?
Yeah, I think this is awesome because we don't talk about it a whole lot. And I know there's is the term with medication, is it tachyphylaxis, where
Mhm.
the drug loses its sensitivity or the response that the body would typically have to it. So and we see that with herbs as well, and I think people assume because it's a natural product, or even with the peptides, it's a signaling molecule. I think people assume that even practitioners, they don't instruct people to cycle off, let those receptors, you know, regain that sensitivity versus that loss of that real acute sensitivity that they have to these compounds. And then they have a diminishing effect.
Commonly, when we talk about receptors, in the literature, they're all drawn out as these little like Y-shaped things. Dan, what happens to that tissue with that receptor when you start flooding it with BPC?
After the initial stimulation, you get a decline in sensitivity of the receptor,
Mm-hmm.
and I think I've even seen where we actually get a decrease in the amount of receptors.
It's the other way around. We increase the amount of receptors, but you decrease the sensitivity. It's
Okay, okay,
twofold.
okay, that's what
Uh,
it is.
yeah, we got to go way back to like early days because I had forgotten about this too, and I had to remind myself as we're preparing. When that signal hits,
Mhm.
the first couple times the body is essentially saying like thank you, like you just unlocked this pathway that was turned off, and this tissue was inflamed, so it clearly needed it. I had oxidative stress happening here. And then, 3 or 4 hits later, it's like I get the message, I'm doing it. Okay. And then like 2 weeks later, you start to really feel the effects. You're healed and you're still getting the message. The body's like, I got this, like I'm working on it, right? And then like 2 months later, this person calls you back and like, hey man, I used up all my BPC. I feel like I'm doing better. Did so well. I want to stay on it. What's happened physiologically? Well, that tissue not only, as Dan so articulately pointed out, like decreases its sensitivity because it's like you look at how many people have kids. Just like because when I go to the store and my kids want something, they're like, "Dad, Dad, Dad." And the first time it's annoying, and then the second time I'm like, "I love you, man, but like you got to stop. You've got your own money for this." And the fifth or sixth time, I just completely ignore it. And we've all seen the kid in the candy store who's like just like throwing a tantrum on the floor. We don't roll that way in our house. We just ignore it. And that's what your body does too. So it stops listening to those cells, that signal, for one. And then the other thing is it becomes harder to satiate. And this is especially true, like the more addictive a substance, the harder it is to curb this. But it happens with things like supplements that people don't think about. So you've got twofold thing. You've got increased number of these receptors on the tissue, and you've got decreased sensitivity. So if I Then that 2 month mark, I feel better and I ask for a refill, and Stitch says, "No, I'm not giving you a refill. You don't really need it. Here's why." And then they're like, "Oh, well, I tweaked my ankle and now I really want it again." So I'm like, "Okay, fine. You tweaked your ankle. I'll give you some more." Well, how much more is it going to take then to get the exact same effect as you had the first time you started taking it? It depends on the substrate, right? It depends on the substance. So for BPC, it's probably, you know, in like the 1.25x, 125%.
Yeah.
But for terzepatide or semaglutide, it's probably a lot more. Why do we know that? Well, when you're dosing these, the typical protocol is you wait 2 weeks, and if they tolerate it, you go up. And then you call the pharmacist and like, "Hey, they're doing well. What do they tell you to do?" We'll go up again. So for peptides like tirzepatide or semaglutide, your tolerance is probably more like 150%. So the next time you get it, in order to get the same effect, you've got to give a lot more.
Too much is never good. And we know that especially, it's very not lost from a holistic perspective. But from a conventional perspective, like you said, like in the hospital, it was like, oh, well, let's give them more blood pressure medication. So in that case, do we, do we have a clear understanding other than, hey, these receptors are going to get disrupted and we're going to get desensitization across the board?
That's a really good question. The most common way this happens is that you first sensitize,
Okay.
and then the body responds by trying to decrease that signal. So it'll try to decrease it by the endocytosis. It'll take some of them up. But then if you keep getting the signal, the body's natural reaction, because the body's like not a static environment. Just in case you didn't know that, it's not static.
It's a shocking idea, right?
I know, it's fascinating. So it tries to basically reabsorb some of those receptors, but then it keeps getting signals. So then it's like, oh, wait a second, like you're trying to give me a signal for something. So then it increases more of them. And this process, just like every other process, is not a static process. So you get a signal and you make more, and then you have to then decrease the sensitivity more. So you take in more of those. And the insulin example is like a really, really extreme one, but it is a peptide, so it's probably worth talking about. But eventually, that back and forth leads to a massive proliferation of more receptors. And again, the more addictive, or another way of thinking is, the more addictive or activating a substance is, the more you're going to see this reaction.
Wow. Okay.
And then eventually you will get to a point where your tissue is saturated. It's got your receptors, your cell surface membrane has basically used all of the real estate that is allotted. If this is the agricultural district, it's got as much agricultural space as it can possibly afford to use for corn that's got designated, and it's not going to be able to give any more. So it has to reabsorb those, which is that endocytotic process.
That's crazy.
Yeah.
It's so interesting to think about, because we know that, as practitioners, thinking of like in an insulin situation, we know excess insulin creates insulin resistance, and it's a signaling molecule. And I use insulin as an example all the time when, when people ask, what is, a peptide or hormone? Like, think of insulin. It has it's stimulating a very particular action in the body. But thinking about like BPC resistance or, semaglutide resistance, same thing. I think we often don't think about that, but any compound that stimulates a receptor is a problem. It's not like vitamin D or iron, where it's like, you have these essential nutrients that you have to have in a certain amount, on a day-to-day. But these other compounds that have these receptors that trigger a response in the body, any of those can have this sensitivity problem and really disrupt those feedback loops.
But it goes deeper than that. Like you mentioned iron, like, there are governing switches for iron. Like I think the
Yep.
Chinese medicine adage is they say copper governs iron. And like
Yeah.
I never really knew what that meant until I started reading Marley Robbins texts, and I started realizing like what ceruloplasmin and all these things do. And I was like, oh man, like it really does. And most people, even people who are iron deficient because they've got anemia, most people actually have iron overload. It's just not usable.
Yeah. And that
And
ferritin, right?
yeah, totally. And the
Yeah.
reason it's like all locked up, and it's because of this same exact mechanism. Like what happens when your body gets exogenous iron but doesn't have the the copper and the zinc and enough magnesium to balance it, right?
Yeah.
It starts to recuperate it and hide it. So like if you got somebody who's got iron deficient anemia and you're like, okay, cool, we're going to give you some like iron or some some desiccated liver or something like that, and you never reassess that or never remind that person, hey, you're supposed to come off this and like fix your diet, do trace
Yeah.
minerals, like you're probably going to put them into iron overload. And iron is the second most oxidative substance known to man, next to
Yeah.
oxygen. So you're essentially telling that person, go ahead and stand out in the rain and rust a little bit early. I don't mind because we just forgot to oil you.
Yeah. And it's fascinating. And then, talking about vitamin D, and another one I thought that was super interesting because, we have to have a certain amount. So having a daily amount of those, not necessarily an issue. It's when we're mass flooding these systems. And, when you have somebody, I've only had two people I've ever seen that had vitamin D toxicity. And the first one came in, she had no idea it was vitamin D toxicity, but the systemic effect that it was having on her was super confusing. She was going to three different practitioners, and she was seeing a endocrinologist for her thyroid. She was convinced it was a thyroid issue because she had tons and tons and tons of fatigue. And so they kept upping her thyroid medication. She was gaining weight. So she was seeing another practitioner. I was giving her GLP-1s. And then she came in because someone had referred her to me. And this was down in Tucson. And I'm having this conversation with her. And I'm like, well, tell me what you take on a day-to-day basis, just going through her health history.
Mm-hmm.
I was just trying to understand her medications. Honestly, it's just part of our job. It's this intake, this health history. And she's like, well, I take 25,000 IUs of vitamin D a day. And I was like, why? That's a lot of vitamin D. Is you just doing this in an acute, situation just for a month, 2 months? What's going on? She's like, no, 3 years ago, a naturopath told me I was deficient in vitamin D and we had a lot of trouble getting it up. So I started taking 25,000 a day. And as you've been doing that for 3 years? She said, yeah. So we ran her vitamin D and it was over 300. And it took so long to get that down. But everybody was looking at, well, maybe it's a side effect of the semaglutide. Maybe it's, maybe you do need more thyroid medication. And we looked at her thyroid markers. They were perfect. They were actually a little high. She just fatigue and nausea, but it was the, understanding that high level vitamin D also shut down a ton of stuff, And with COVID, we've seen people do that with vitamin D, zinc, big one. I've seen a lot
Zinc
of,
for sure.
yeah, a lot of zinc toxicity, but seeing how these mechanisms shut things down and make people, they're engaged in what you would otherwise consider a healthy behavior, but it was taken too far and it became unhealthy. And so it's so interesting to think about it beyond just a peptide or a hormone or medication, but also something as simple as like iron and vitamin D, right?
Oh man, there's probably a small handful of things that everybody needs to take on an almost daily basis, right? Like we need more magnesium, we need more trace minerals. A moderate dose of vitamin D probably makes sense. Like if you're in functional medicine, these are kind of your basics. Um, omega threes is a little bit debatable, but at least a moderate dose of those most people benefit from. I would throw in there like sea veggies or fucoidan or something to that effect. Protect the endothelium or the endocalyx inside blood vessels because we just don't get that. But then like there's a whole bunch of stuff that we hear on a podcast or we see or like somebody has a cool ad and I'm like, I want to look like that.
Yeah.
And we add it and we don't think about like, is this something that I need indefinitely?
Mm.
Methylene blue, like when you
Yeah.
take methylene blue, it's the Swiss Army knife of mitochondrial support. But if you get used to it for a long time, your body gets used to that extra load of energy in the form of light that gets carried by methylene blue to where you need it. And then what does it do? Like, it's like, oh, sweet, I'm getting more energy from here. I can shut this pathway down because I don't need to waste energy on it. So even
Yeah.
something like that, you know, you have to think about breaking the cycle. So with our patients, I'm typically counseling them, okay, you use it like 3 days on, 1 day off, and then take a little break and then do it again.
With the with the with the peptides and some of the things that we've talked about, where do you see or where you feel like the biggest overuse is happening?
GLP-1s, like
Yeah.
without question. Um, Everybody wants an easy switch. I want an easy switch. Like I want the easy buttons, so
Yeah.
I don't have to do the hard things. But that's just not reality. And it's become an easy button for weight loss and appetite regulation. I think we have to then get to the practical thing. So what do we do with this? Like how do we think about it for not just GLP-1s, but all of them? I mean, I mess around with C-Max and C-Link all the time because they certainly help me concentrate. I get a big cognitive and focus benefit. Probably got a little ADHD that I don't medicate with. Um, so maybe that's my medication. But if I'm using those every day, it's not going to be long till my body stops responding to them.
Having a process of cycling, what does that cycling need to look like? Because I know like a lot of the peptides, like BPC, it's typically dosed 5 days on, 2 days off. And if they're doing that for a month, like we see we see typically in the office, if people do that for about 3 months, that's a good that's a good kind of treatment and therapeutic like time frame. And then when you tell them, beyond 3 months, we don't see that it's awesome anymore. It's like we want to take a break. So,
Mhm.
is I think, does the 5 days on, 2 days off slow down that loss sensitivity a little bit so that they can have a longer therapeutic window? And then, after 3 months, hey, now it's time to take a break. Let's let all these things clear. Let's give the body a chance.
Yeah, it's a really good question. So it probably does. They have the concept in Great Britain of like drug holidays, which we don't really have in the U.S. Um,
Okay.
a few psychologists or psychiatrists will do it with like ADHD meds, but it's the same kind of concept, right? If you can take periodic breaks, and then take a longer break in the summer for like ADHD meds, you're less likely to get that sensitization. So for sure, and then there's some ones that have really good science, like the growth hormone secretagogues, all
Yeah.
the tesamorelin, zipamorelin, CJCs. Doing the 5 days on, 2 days off, you're going to more mimic human physiology because human physiology, you're going to make more growth hormone when your body is growing more. So like, the toddler period, neonatal, uh, infant and toddler, puberty. And then there's spouts throughout life where you're pushing yourself harder and you're going to see it. If you watch somebody's labs really close, you can see like IGF-1 will increase a lot if they're doing a whole lot of HIIT workouts
Mm-hmm.
and they measure it right afterwards or resistance training.
Hmm.
So you're going to mimic that a little bit,
Yeah.
but I want to get a lot more nuance with my folks. So if I'm using something like that, you don't stay in a growth phase for long periods of time.
Yeah.
And I think of these folks, because you and I, we kind of had this similar practice, right? We work with very few people really intensely,
Mhm.
and we have a lot of like mindset and strategic and psychological coaching because that comes along with what we do. Um, But then we get like nuance. So why do you want this? So my goal is I want to live to be 120 and be able to rock climb, 512, 513s, whatever, when I'm 80 years old. Okay, cool. It's this very specific goal. It's a very achievable goal in my mind. But how do we get there? Well, we're going to get there by starting to split. Okay, what do we need to do to get to that goal? And then that will determine how we cycle these things. So one, you have to maintain your musculoskeletal health, which is what I would call the growth phase, mTOR. But you also have to push the cellular cleanup phase. Hence the seasonality of life, right? There are periods when we're pushing hard and periods where we're taking it easy. So I start to think about cycling these peptides just like that. If I've got somebody who's like microdosing semaglutide, which there's some really interesting literature about, or tirzepatide, then that's great in that phase of life when we're not really trying to make huge gains, but it's going to do you a disservice if you're trying to stimulate your musculoskeletal health and repair injuries and prevent injuries. Right? So during that mTOR phase where I'm focusing on musculoskeletal health, I'm probably going to be recommending more like mitochondrial support. Mm-hmm. I might, depending on their injury propensity or what they're dealing with, we might add in some tissue repair stuff. But we're going to probably take a break on, and definitely like the growth hormone secretagogues, but then we're going to probably take a break on some of the other ones, right? And then we'll flip that when we're in that, it's called the AMPK phase, that cellular cleanup phase, right? So they'll probably have a more narrow eating window. They might fast a bit more often. They might be focused on SS31 tissue support.
Yeah.
And then we'll go back and forth. And I typically have found the sweet spot where most people, they tend to seasonally train or seasonally have sports. And it tends to work out where they can do like 2 months on one month on the other, or 3 months on one and 1 month on the other. And that tends to work pretty well in people when they're a little bit younger, a little bit more active. And then the scale will flip or go the other way as we age.
The program design protocol process that we've put together is so critical because you can just like get on and off of all the different pathways. So you can always be, priming different areas of the body as opposed to just like nonstop kid tugging at your shirt sleeve saying, "I want that candy."
What we're going to do now is jump into the role of consciousness when it comes to health, thinking about placebo, nocebo, and just overall how, anything that's going on cognitively. I hate when people tell patients that, it's all in your mind. I think that's the worst place for it to be, because that's where your brain's at, and that controls everything. I'd rather, people are like, it's all in your mind. I'd rather be in your pinky toe. Being in your brain's a worse place for it to be because that's going to have physiological changes and responses and affect anything that we do. So this role of consciousness, especially, open the conversation to placebo and nocebo, I think is incredible to talk about, but also to make sure that we're educating clients on it.
The study that looked at the power of belief in terms of treatment efficacy. And the summary of the study was that if a patient didn't believe or wasn't confident that a intervention was going to work, it was less likely to work. If the provider was less confident that it was going to work, it was less likely to work. If the patient believed it was going to, it was more likely to. If the provider believed it was more likely to. But if both of them believed that the treatment was likely to work, it increased its efficacy by something like another 17%. It was crazy. And I was like, that doesn't register with anything I was taught. The study Dr. Dan's referring to is these patients went under general anesthesia and got an incision. And then some of them got a sham surgery and some of them got a real surgery on their meniscus. And they were all told that they got the real surgery. And they got the same treatment protocol afterwards. And the ones who did the best are the ones who didn't actually have the surgery. And it was an astronomical difference too. So what happened? What made them better?
Right. It's that power of belief, right?
Thank you guys so much for being here. We'll see
Take care,
everyone.
everybody.
Everybody.